And the reason why it's so variable is a little bit mind-boggling, but I think it will be fixed hopefully very soon, because the ClinGen panel, the report where we do very careful analysis of all the gene disease association for complement-mediated TMA should be coming out. Is it next spring, maybe? Something like that, maybe a little bit later than that. And that should set the tone, or should become the baseline for all the labs, because we've done all the work, very, very carefully. And the hope is that the effort that we're taking for that will pay off, and will make things a little bit more even across the board.
Right, and I'll talk about the ClinGen effort as well. So in terms of, you saw there were a panel with 8 genes, and then there was a panel with 40 genes. We've alluded to it, but what are the pros and cons? Is having 40 genes necessarily better? Brad, do you want to go again?
I think it will depend on what the gene is and what evidence there is for disease association. Like in one of these panels, there are many complement genes that are on the panel, but those complement genes have not been definitively associated with AHUS disease, or with segregation and family pedigrees. So just to have a complement gene doesn't necessarily benefit you if there's not been any described association.
Right, and that's exactly my next question, because all of us, I think, who are in the field get at least 1 or 2 reports a week, or maybe more, to interpret, and this happens all the time for some of these genes that we do not have evidence that they're related to, but you get a variant of uncertain significance, and the patient has a clinical phenotype, and the clinician sends you the report. What do you do? What do you tell them? Mathieu, you want to say something?
I want to comment, maybe a plug and a comment, because there's a gene there, ST3-GAL1, that I work on, and it's not published. And it's a beautiful, hopefully you're going to see it soon, but I'm shocked that a commercial lab is testing for a gene that doesn't, I can tell you, there's 0 publication about this, because I'm working on it. And I guess the cat is out of the bag. So if you have a patient with consanguinity and atypical HUS and you don't know what's going on, it might be that, but talk to me. Don't. But so this is not serious business, right? They have no business putting that in their report, because what are you going to do, right? Like if you get a report that your patient is homozygous for ST3-GAL1, you're going to be like, okay, so what does this mean?
So that bears the question. I think Brad mentioned that sometimes there are 1 or 2 publications that allows the lab. What happens when there is no publication? Why is a gene like this included in the panel? No answer, right? We don't know. Exactly. Okay. All right. And I know, Mathieu, you covered this easily, MLPA. I do want you to or maybe Meredith, one of you can please reinforce what is MLPA and why is it important to have it in the panel. And I bring this up because for one of the labs that does not offer MLPA, they said that they can do it, but they only use it to confirm at this point. What they actually use is a validated next-gen sequencing-based copy number variation algorithm that they use routinely. And that these algorithms have gotten to a point that they are comfortable doing it. Any comments on what that may involve, what that means?
I mean, I'll start and pass it along, but I think it's even important to point out what MLPA is, maybe different from lab to lab. So the MLPA for the common factor H related 3, factor H related 1 deletion, many labs will offer that because it's a well-described methodology, but MLPA looking across the entire CFH-CFHR region is much more complicated, and there are much fewer labs doing that, and doing that with sound methodology. So whether someone has an MLPA that is going to pick up more unusual or rare copy number variations, rearrangements, may depend on the MLPA methodology that they have. And I think it's important partly to help demonstrate risk for the factor H autoantibody of the common deletion, even if it doesn't itself have disease association or a strong disease association.
So do the labs report their methodology? I know there is a whole paragraph at the end of the report that talks about it, but it's in the fine print, and the clinicians are not going to read that. Nobody has the time, understanding. So how are clinicians supposed to figure out whether that particular lab has the appropriate methodology for MLPA or not? Meredith, you want to take that?
That's one of the biggest issues right now, is that you get these reports and people see a positive or a VUS and they read it and it sounds really convincing for their patient. But I think, like you were saying, is they need to say exactly what the methodology is in the variant of unknown significant to kind of let the clinician know a little bit better what they've looked for and why they think this would be more positive or why it would not be negative, or why it would be more on the negative spectrum. Because I think right now there's a lot of variation. The other thing I think, is that we get a lot of calls from clinicians who've already made plans for what they want to do before they've really read the fine print. And I can't underscore the importance of using genetic counseling to help kind of interpret, and using all of the databases to help interpret as well, because you may even read something that sounds convincing to you, and then you look on ClinVar or Nomad and really feel like it's not very convincing anymore.
Exactly. And something that I think, Mathieu, you covered very nicely, and you mentioned that, when there is sequencing, it's important to have information on what is the read depth, are there parameters, kind of on the lines of what we've talked about MLPA. And my question is this information in the report? And number one, and number two, what are some parameters of reliable sequencing in terms of read depth and sensitivity for the bases covered?
So most good reports will give you a broad sense of the amount of base coverage. They should also tell you if there were some exons, if it's an exome, if some exons were not covered or poorly covered, so that they couldn't make a call. And then it's for you to decide if it's worthwhile to go deeper, to resequence for that exome 19 I mentioned earlier. And then you, for example, if it were the exons covering the SCR domains that Richard explained to us that are not covered, the ones that are critical for its function and where the mutation seem to aggregate, and you get poor coverage there, I would say absolutely, go for it. But then it means that you have some deeper understanding of the biology and the genetics to make that call. So it's usually there. I would say most clinicians are they're not super knowledgeable about this, and hopefully the genomic or genetic literacy will increase over time. But I don't think it's reasonable for us to expect that clinicians without training in genetics will go to that next level. I think it's incumbent on the report to flag these and say, do something, because often they will just say no variant found, and the clinicians will see that, close the file, and just say genetic testing was negative. They don't go and say what was not, where no conclusions could be drawn.
If I can add one other thing, even looking at the reports that are in the handout, whether a genetic lab, and especially a commercial genetic lab, is going to give you good information that their testing will have good coverage can be quite deceiving. So on one of these, if you look carefully, factor H is asterisked, yes. And that means that they don't have adequate coverage for some of those important regions, largely because of the homology of those regions to other factor H related genes that can lead to re-dropout, promiscuous primer binding, things like that. So it's not going to be clearly stated by this commercial lab that they have an inferior testing methodology to another academic
right. The asterisk is,
lab.
and it's in the report, it's in a fine print, it's there at the bottom in the last page. I copied and put it in there, but I took it off because it's very difficult to interpret that information. And to the same question, what about turnaround times? We had one lab that offers, if you really ask for it, less than 48 hours or up to 5 days? What is the average time it takes to do sequencing? And what do you make of labs that offer sequencing that quickly?
I think one of the problems with quick turnaround time like that is that they send you a ton of variants with unknown significance. They don't have the time to actually look at the variant specifically and give a very thought out and specific report for each patient. And so you get a lot of data, but it doesn't really tell you much about what you need to know for your patient. So while the turnaround time may be short, the onus then on the clinician to interpret is a lot higher. And I will say a lot of times, especially in a clinical setting, I don't think you need that quick of a turnaround time. If you're truly concerned for atypical HUS, you treat and you treat appropriately. And then if for some reason they receive a dose of eculizumab that they don't need, the worst cases, they got a dose of eculizumab when they were very critically ill. So I think it might sound appealing, but it doesn't, you don't truly need it that quickly.
I think that's a very critical point, because we shouldn't be using, and we can't use genetic testing right away to make a treatment decision, which has to be made in 24 hours or less. And most of these reports are used to really determine what the duration of therapy is going to be. So, I guess, do you envision that genetic standards, panels, reporting can be made uniform across labs, commercial and academic, and what needs to happen for that, so that no matter where a clinician is, if they're ordering the testing, they don't have to pick which lab to, because that's another question. Where do I send the testing? What do you guys think about it? Can that happen? And what would the process look like?
I think when we have the good information that will come out of ClinGen, it will make things easier. And this is not something that's completely new. And one easy way that's been done in other spheres is to have a standard panel of unknown variants where all the labs are being sort of tested for these planted variants, and just to assess their performance. Are you going to pick it up or not? For example, I think you were mentioning about the exome base copy number variation assay where they're quite confident and then they do MLPA confirmation.
Yeah. So that was one of the labs that, and actually it's one of the academic labs that they don't do MLPA right now, but they use a next-gen sequencing based assay.
But that's tricky. I mean, it might work potentially, but some of these complex rearrangements would be really, really difficult to tease out bioinformatically. Because at the end of the day, if you remember the graph I showed you with the coverage, really what you're looking at with copy number variation is you have an expected number of reads for a given exon, and you're looking at multiples of that up and down. But there's some noise to this, and to make a confident call that one exon is missing or is added, it can be really tricky. And the other thing is, if you get a complex rearrangement, it's possible that your capture is not working, potentially. So I don't know. I would put a big grain of salt on some of these claims. The only way that you could be sure that it works is if you were to do these standardized tests where all the labs are offered a certain range of variants, and you see if they get the right answers. And it would be good for all the labs, because you don't want to miss pathogenic variants.
True. And, I know you and Richard have mentioned ClinGen a few times. I do want to take this opportunity to talk about the work that we've been doing at ClinGen now almost for 2 years. So it's actually an NIH-funded initiative where a group of us gets together, and I'll share who all are involved, where we are looking at the relevance of genes and variants, and currently genes and eventually variants. And I co-chair that with David Kavanagh and Yasser Kaliskan. Our coordinators, it's Pam, Alicia, Julie, and in the past Ryan. It's been an immense learning experience for me, definitely understanding how ClinGen and how we what evidence we use to really curate these genes, and what goes into defining the level of pathogenicity, whether it's moderate or limited. And we have our curators here. Genevieve is here, and Yasser and other people, Judy. they go into the literature, they go do an in-depth study of figuring out every every literature that is being identified based on that gene, and they bring it to the panel, which is our expert panel. Mathieu and Richard are part of that. Judy is part of that. And we meet every month, sometimes twice a month, for an hour or longer. And we spend an immense amount of time and effort really dissecting this literature to make a determination whether that gene is associated with complement-mediated TMA or not, and what is the level of pathogenicity. And it's taken us a long time, primarily for the reason that Mathieu mentioned. It's, complement-mediated TMA is not a Mendelian disease, and a lot of the framework that Klomjit has designed is for Mendelian diseases. And so it has taken a lot of effort, time, involvement, resources to really even get to this point. We are not done yet. These are some of the genes that we have finished curating, and these are all published on the Klomjit website. And thrombomodulin is something that Mathieu was mentioning. In our panel, in our group, we have refuted that gene as being associated with complement-mediated TMA. But, what you said, Mathieu, is kind of what I thought as well, is that, at Klomjit, we are doing this. This is going to be amazing. It's going to change the course of action. But guess what I found out? There are two other companies who are doing gene curations similar to what we are doing. So there is a genomics company called Genominon that uses AI and some expert curators to produce these curations. And they actually had a paper in Nature that they talk about their process. I literally found this out 3 days before the workshop, so I was not aware of this. And then Invitae uses a different framework compared to what we use. They do gene curations. They have a group of both certified geneticists, counselors, PhD scientists who are on their panel, but they're lacking clinician involvement. And what Klomjit has found is that there is a discrepancy. When we find something as limited, it is being curated as strong or above with Invitae. And we found that with thrombomodulin. When we refuted that gene, it was identified as a strong association by Invitae. And I think one of the issues, Richard, you have something to say?
Share with the audience. The audience what it means if a gene is classified as moderate versus definitive versus
Right.
limited.
Exactly. So for example, when we go back to, so some of these genes you will see definitive, moderate. So the data that we are using at Klomjit, and that's based on the framework, is that you go into the literature, you find out what is the genetic evidence in terms of, the number of patients that have found to be associated with variants in that gene. Is there functional data that is available? And not just any paper. That is why we are on the panel, is we are dissecting every paper that comes out with functional information to really figure out, is this reliable functional information? Should this be involved in the evidence? We are looking at any kind of structural information there is, any kind of segregation data. So there is a lot of evidence. And despite all of that, something like factor I, which we know is a complement gene, only reached moderate for something like C3G, primarily because of how strict the evidence is. And so when we publish some of this, there is going to be there's a description of what evidence is used. And so that's kind of what Richard was alluding to, is that we use a lot of information and we use our clinical expertise, information that we know that goes into this evidence. And I think that is something that is lacking, in my opinion. Again, I'm being biased from some of these two, other curating companies. And and I think Meredith alluded to this earlier, that some of these are for-profit businesses. They're using high throughput methodologies. And so they're curating these genes at a much higher rate compared to, it's taken us 2 years to curate like 7 genes. And so even though, like Mathieu said, I was under the impression we do at Klomjit and it's going to be, the solution to everything, but I think there is still more work to be done. It seems like we'll have to get together with these other companies, if possible, to figure out why there are differences. Because even if we put something out, but if there's a difference, that does not solve the problem of what goes on these panels. So I think what I want to do now is, with that background, I'm going to share with you all an actual case that I was consulted on last week, and I'm going to share with you the report for that case. And And we'll go over what the variants that were identified. So this was a patient who's a 68-year-old male who developed TMA after a kidney transplant. On day 3, the patient had systemic manifestations, hemolytic anemia, thrombocytopenia. Because of the long cold ischemia time, the patient was expected to have delayed graft function, meaning the patient had to start dialysis soon after transplant. The patient was started on eculizumab and switched to belatacept, which is a medication that is often used instead of a calcineurin inhibitor to spare the calcineurin inhibitor, because oftentimes it is believed that the calcineurin inhibitor causes trouble or causes a TMA. And now Christoph is here and he's published on that. So the patient responded very nicely to eculizumab. There was hematological response within days. And they actually were able to do a biopsy in a transplant patient, which often is complicated because of the thrombocytopenia, but it showed extensive thrombotic microangiopathy. And this is the actual email I got from the clinician. It said, we have a case where the biopsy shows extensive TMA, and there was clear evidence of hemolysis, but the genetic testing showed many VUSs at high prevalence in the population, except 1 or 2 were rare factor H variants. And I think, as you can appreciate, there's a little bit of a misunderstanding on what high prevalence or rare variants mean in this regard. It is possible that the TMA is not related to complement disorders, but I'm hesitant to automatically disregard the VUS. So are you able to assist with the interpretation or functional testing? And so the report, here is the report, and you can't read the print, but what I'm going to do is I will, and you have it in your handouts, I'm going to just kind of go over the variants here. So this was reported as a variant of uncertain significance. On the first page, there is an ADAMTS13 variant reported at position 795, alanine to valine. It is a VUS and likely benign in ClinVar. It has been reported in a patient with TTP that also carried another variant, and therefore the role of this variant was unknown. A second ADAMTS13 variant was identified in this patient at a minor allele frequency of 0.003, benign and likely benign in ClinVar, reported as a polymorphism in one study, reported in a congenital TTP patient, reported in a compound heterozygous state in an aHUS patient. Third variant on this page were 3 additional heterozygous variants in ADAMTS13. One was synonymous. There was 1 missense and 2 synonymous and 1 missense, but all of these were benign or likely benign. Then on the second page, they have reported a CFHR5 variant, which is a heterozygous nonsense variant. Generally, nonsense variants are deleterious. This is from the report. I didn't make this up. Generally, nonsense variants are deleterious. This one occurs in the last exon and does not affect protein function, classified as benign or likely benign. Then there is an MCP or a CD46 variant, which is a variant which is synonymous, classified as benign. But then there are factor H variants. There are 3 of them, 2 synonymous, 1 missense, classified as benign. And this is kind of what I think Mathieu was alluding to. Factor H or factor HR related one, unclear where this variant is because of the high degree of homology that Richard showed in his talk. It was unclear where this variant sits, in H, HR1, or both, but it's not clear. Then there is a missense variant in MMA-CHC, which is classified as benign. And then another heterozygous variant in CFHR5, which is classified as benign. And then there's another third page of the report that talks about factor H variants, 2 heterozygous variants. There is a missense variant. Both are classified as aHUS-associated mutations, but since the MAF is high, they're likely not pathogenic. Then there is another homozygous missense variant in factor H. One study reported that this was associated with aHUS in 7 patients, but there was a study that did not show functional defect. Then there are factor H variants, homozygous missense in the serine to isoleucine that co-segregates with the valine to isoleucine. This has also been reported in an aHUS patient. 5 polymorphisms in MCP. They are in the normal population, but enriched in the patient population. Their patient was homozygous for the valine to isoleucine and the 402 variants, which are common in the risk general population, but increased risk for dense deposit disease. And then the patient was negative for C5 polymorphisms and heterozygous for the large CFHR3-1 deletion. So I can go over the variants, but this is the lab, this is the kind of report I get twice a week, like I said. And it takes a lot of time to dissect through this. And I cannot imagine the clinician who's dealing with 500 transplants a year has the time to sit down and look through this. But they have to make a clinical decision for a patient. So my question to the audience is that based on this report, let me see if I can click on this. What are you going to do with the patient? Well, first of all, do you think there is a genetic etiology for the TMA? Do you think there is no genetic etiology, or do you think you're not sure if there is a genetic etiology?
Just a quick question. It was only post-transplant TMA, right? No.
Yeah, we did not have any native history. This happened after the transplant.
And the cause for end stage, unknown?
That's a good question. I have that information.
And
I think it was diabetes.
Okay.
Mathieu? Let me check.
and are you going to talk about donor testing?
I'm going to ask about donor testing.
Okay, because that's another interesting.
It is going to be a question for you all. Although this patient received a deceased donor kidney, but if there was a living donor, yes, that question comes up. So, yeah, I think a lot of people are unsure, right, about what they want to do. Some of them feel that there is a genetic etiology and they would consider treatment. All right. We'll go to the next question here, which is, how are you going to treat this patient? Will you treat this patient with anti-complement therapy indefinitely? Would you not use anti-complement therapy at all? Would you stop the therapy after 3 to 6 months if the kidney function recovers? Or would you stop it after 3 to 6 months if the kidney function does not recover or you're not sure what to do? So some are unsure, some would stop it, some would treat indefinitely, right? Or no, yeah, there are some who would treat indefinitely, okay? And most of people would want to stop after 3 to 6 months. Okay, so I think it would be great if I went back to the report and asked our panelists what they thought about each of the variants. Would that help? Yeah, I think that would be great. That's what we want to do. All right, we are going to start with the Adam TS13 variants. What do you guys think about the variants on this page? Meredith, you want to take it?
I think the patient doesn't seem like they have TTP, but I think the easiest thing to do would just be to send an Adams TS13.
Which was normal in that case.
And there you go.
Yeah, perfect. All right. What about, so let's start with actually CFHR5. Before I have you answer that question, we're going to have somebody from the audience answer this because we actually have door prizes. So, and what I want to ask is, if you have a variant in CFHR5, what kind of variants are thought to be problematic? This is a nonsense variant, which means that it will lead to the protein not being made in CFHR5. What kind of variants would be problematic in CFHR5? Anybody? Richard? Oh.
Thank you. Based on the knowledge
Peter, you
from...
want to introduce yourself?
Okay, I can
No, you can
step
sit.
up.
You can sit down.
Sorry?
You can sit and introduce. That's
Okay.
fine.
My name is Peter Sipfel and I come from Germany. Based on knowledge that comes from Factor H and FHR5 has the same structure, a mutation that affects the cysteine residue to a stop residue results in a lack of protein secretion. So in this way, this allele is not secreted, and the prediction is, as a heterozygous, that the patient has half levels, 50% levels of factor H. We know something about factor FHR5, but not much, and it can be highly speculated, but I think it's highly relevant.
So, so if the CFHR5 is not made, that is relevant. Peter, is that kind of what you believe?
And this way, yes, you are right, but this is a heterozygous mutation. So that means 50% levels
is
of the
not.
protein, the other allele, the other part of the genome, likely makes FHR5 in this way. I hadn't time to look at all the details.
Oh, totally.
Maybe it's also affected.
Richard, you raised your hand. Did you want to say something?
Firstly, welcome, Peter, and he shouldn't be allowed to answer because he's spent his whole life studying the related proteins. So he's a ringer. But factor H related 5 circulates in exceedingly low levels. And so while I agree with Peter that if you have a null allele, it's probably relevant to something, but we don't know what yet, the way the related proteins, related 5, is known definitely to cause disease is when you get those fusion proteins that I showed you. And I showed you examples with complement-mediated TMAs, atypical HUS, and the same fusion proteins. And Peter's done a lot of this work. If you duplicate the first 2 SCRs of the relateds, and especially the type 1 relateds, which is 1, 2, and 5, then you get a C3 glomerulopathy. But even though I know in my heart of hearts that causes C3G and those others cause atypical HUS, the genetic level of evidence on the ClinGen committees is limited. So as a clinician, if I find this in my testing and I send you a report, my report will say pathogenic MORL criteria, internal criteria, but the ClinGen report will only say VUS. They can't call it pathogenic or likely pathogenic, even though many people in this room have published articles, followed families, done functional studies that show it's pathogenic, and that's a huge problem.
Right, but the point I was trying to make, Richard and Peter, was that for factor HR5, if there is a loss of function and there is low levels of protein, do you think that is going to cause trouble for a TMA patient versus what you meant exactly? So that's kind of what I'm alluding to, is that it has to be in some way a gain of function for these variants, whether it's in those hybrid genes, to be able to be problematic. Mathieu.
So, and another thing you can do, so if you go to Nomad and you plug in your gene, your favorite gene, let's say complement factor H5 or complement factor H, I would encourage you to look at the top right corner, because there's really good data about the predicted number of missense, synonymous, and loss of function variants based on the gene properties, basically how big the gene is. The bigger the gene, the more variant you expect to find. But what is fascinating is now with the data set we have, you can see whether the expectation and what is actually observed correlates. And if there's strong selective pressure, especially for loss of function, you're going to see a dramatic difference between the expected and the observed, which is exactly what you see for complement factor H. And for complement factor H5, it's actually more loss of function variants than you would expect based on its gene size. So this.
I'm just doing what he said. I'm just looking at Nomad, and I picked one loss of function variant in factor H related 5, and it's present in 1 in 300 people. So, I mean, it's not causing a rare disease.
Exactly. All
and
right.
that's just one of them.
Right. Moving on to the MCP variant. It's a synonymous variant classified as benign. What do you guys think is the significance of synonymous variants? I know, Mathieu, you mentioned a little bit, but do you think it should be reported? How do you interpret a synonymous variant? Does it have epigenetic effects? What do you think about it?
You do have to be careful that a synonymous variant could change mRNA stability. So there could be some subtle disease impact, functional impact, even if it's synonymous. But I think reporting that without a clear understanding that a property like that exists is ultimately confusing more than confusing more than beneficial.
Right. Similar to that, I think we have these synonymous variants in factor H. And
Maybe one more
Yeah,
thing
yes,
is
please.
if anybody gets a synonymous variant where the base that's mutated, so let's say this amino acid is the last one of an exon and the last base is mutated, this is also a critical spot for splicing. We usually think in +1, +2, and a little bit beyond that, but +1 and +2 are usually the bad positions. When I say +1, +2, I mean outside of the exon, but position 0 is actually critical too. And sometimes just changing a base, it looks like it's doing nothing, but it has a dramatic impact on splicing. So just, and it can also happen in the middle of an exon if it really, and this typically will only occur if you have a weak splice site and your change in base creates a strong splice site in the exon. A little bit trickier to do, but there's relatively good prediction softwares for this, in contrast to the other prediction softwares we discussed.
So something like that, a genetic lab can report, right? Go ahead, Richard.
So if as a clinician, you have a strong suspicion that it's complement-mediated TMA based on the clinical picture, and if in the genetic testing, the only thing they find is a synonymous variant that's never been reported, then I think that those are worth studying if you can get a lab to do that. And they can change an exonic splice enhancer, they can cause cryptic splicing. And to figure that out, you have to do wet lab experiments doing a splicing assay.
Excellent. What about some of these others you talked about? I think, does the fact that the lab couldn't figure out that the variant was in factor H or factor HR1 goes back to the answer about not having the appropriate methodology for the testing? And the missense in MMACHC, any thoughts on that?
My understanding of the cobalamin C related HUS is it's a recessive disorder.
Right.
So reporting something as heterozygous, yes, it's benign, but it's also benign because it's the mode of inheritance is different. I'm sure there are cases where heterozygous variants can have some functional relevance, but I don't know if you all would disagree.
One thing to be careful is sometimes the variant will be labeled pathogenic, and clinicians will think that it's a pathogenic genotype. So I get calls a lot from my colleagues saying, "Oh, this is clearly disease causing." So the variant itself clearly is pathogenic, but the genotype is not, because it's supposed to be recessive and it's heterozygous.
Similar to the
So that's really
CFHR5
important.
story. Yeah.
Because the word pathogenic pops to the clinician, but you have to distinguish allele versus genotype.
It's pathogenic for that disease. And so this is the final page of the report. Anything here that strikes you, especially the factor H that have been reported in patients of HUS, or those have been reported enriched in the population, anything that strikes you that would concern you on this page?
If you have the time or a keen fellow, you can probably dig which publications and go read, what was the level of evidence. I can tell you, often I'm not sure if it's I think the peer review is playing a little loose with accepting variants that have no business being labeled as pathogenic. But then the telephone game starts and everybody says that it's pathogenic. But if you go back and check, sometimes the phenotype doesn't even match. So just some.
Right. So Meredith, I wanted to ask you, if you got this report from a clinician, what would you tell them? Do they have a genetic cause for the TMA in the post-transplant patient? Yes or no?
I think it's pretty tricky. I don't think that there's anything on this report that really pops out to me as glaringly pathogenic. And I think back to the point of, you can read this whole report, you can get a fellow, you can go down 1,800 rabbit holes to figure out, where all of these stand. But I think partially it's just you had a clinical response to treatment. I think you see what that clinical response is. You try to remove that treatment and see what the response is. And if you still have reliance on complement inhibition, then you probably need to dig a little bit deeper. But I don't think anyone, has the time when you're getting these reports twice a week to dig and dig and dig in something that looks pretty benign.
Excellent. Yep. And so that is kind of what I told the clinician. I did not find anything that was concerning to me on the report. And based on the genetic report, you could not make a determination that the patient should be treated with eculizumab forever. My suspicion is that it was an older patient, had long cold ischemia time. There could be so many other factors post-transplant that could be causing it. Maybe there was a transient activation that caused the TMA, and this patient should probably get better and should not be kept on therapy. And that is kind of what concerns me, is that, yes, we have, we all worry about not starting timely treatment on our patients, but I also worry about some of these reports misguiding clinicians on maybe patients being kept on therapy for too long or wrongly treated. Go ahead, Brad, if you had to say something.
I would just caution in the opposite direction. I wouldn't use a negative report. This is essentially what Meredith was saying. Don't use a negative report to say that complement-targeted therapy is not appropriate, because we certainly know that patients, even with the most rigorous testing, who don't have pathogenic variants, can still have a response to therapy.
The other question we've talked about turnaround times. I wanted to ask a question about some of the labs do allow the clinician to check a box to see whether whether they want a VUS to be reported or not. Any thoughts on that? And if the box is not checked, a VUS is not reported. Agree, disagree with the practice?
I think that's ultimately putting into the hands of someone who's not experienced in interpreting that information, some potentially dangerous or problematic information. So I would say the option shouldn't be given to a clinician necessarily. I don't know if you all would agree or disagree.
Go ahead, Peter.
Thank you. I have a comment regarding the genetic report, and that is the FHR1B deficiency, which is heterozygous in this situation. And this panel so far very much focuses on genetics, which is absolutely right, but additional parameters, Richard mentioned it, that the deletion in this way, where it's homozygous, comes with autoantibodies. So that's the issue in this way, in addition to follow. Maybe we can
Right, that was a heterozygous deletion. Right. And often it's the homozygous deletions that are associated with factor H auto.
You are absolutely right, but nature is not perfect. There are atypical HUS patients who have both copies and who have clear antibodies.
Right.
So that's why in this way, by picking up and saying could be an issue, and test for antibodies can be removed.
Exactly. So I think I typically recommend doing genetic and autoantibody testing at the same time, regardless, because we don't know what the genetics is going to show. But in association with the heterozygous, I think we believe the homozygous deletion is. I think we are going to move on to the next panel, because I did want to talk a little bit quickly about guidelines on what should go into a report. And I think that came out very nicely in the panel discussion. That synonymous variance, unless the lab can really tell the clinician what that means, benign polymorphisms, things that are unclear should not be on the report. And if this was by one of the other labs that we trust, I think they would have reported it as a negative report. Am I right or am I wrong? Okay. All right. Any questions from the audience, Janet?
I guess it's just a comment for the sixth line, what should be in the report. I think this lab is very annoying me in the fact that they blend the variant information with the gene information, and that the standard of genetic report should have a clear distinction of what is a gene level of evidence and what is the variant. And once they blend it in the same paragraph, even between the sentence, it's just sometimes make a gene level evidence to support the variant that are synonymous or benign, which is making clinician very confusing. So I think just to point it out.
There are a couple comments in the chat that I'll quickly point out, and I think it alludes to what, Matthew, you had mentioned. This is a physician from Brazil, and she mentions that she asks if any of the synonymous variants that were on the report were in the last exon, because she said she had a patient that happened to her, it was wrongly predicted, and then it actually affected splicing. So I think that point is well taken. And then the second question is from Dr. Rubin. He says, I think that he understood that the patient had TMA, and he's wondering if, and because the patient responded to anti-C5, he's wondering whether the report is current enough that they're missing any variants. But this is from about a week ago, so yes, it is quite current right now. And I think you had alluded to risk haplotypes, Richard, and the question is, I don't know, I don't think we saw that reported. And I wanted to just kind of take 2 seconds and talk about the fact that, do you report risk haplotypes regardless of whether you find a pathogenic variant, or do you, no? Okay, excellent.
Unless they're segregating with a pathogenic variant.
Excellent. All right, any other questions from the audience? All right, then, so we are, what's the time? We should have coffee outside if you want to drink, but we won't take a break. We're going to go into functional testing, but we'll get started on this, but feel free to go in and out and get yourself a drink or something. And in the meantime, we'll have our panel.